here talking about cognitive impairment and opioid use disorder. We're welcoming professionals and community members from all across the country. We're excited to have you join us. This is one of multiple presentations on this subject. Dr. O'Connor will be joining us in a moment. Again, we are going to be on Facebook Live, so if you do talk during the presentation, your video feed will pop up. Otherwise, everyone will be seeing Dr. O'Connor. If you get kicked off, please feel free to join us on the Facebook feed. You can also put comments for the whole group to see in chat. If everyone wants to pull up their chat, set it to, what would it be, all?
Everyone.
Everyone, set it to everyone and say hi real quick so we can test that out. That's the chat feature. It goes to everyone. If you want to do a Q or a question anonymously to Dr. O'Connor, you can use the Q&A and Kristen will be monitoring.
Actually, there's not a Q&A feature in the meeting settings. So, but I do believe you can, instead of choosing everyone in the meeting, you can choose Carrie or I, because we are hosts. So if you set it to that, it'll come directly to one of us.
Fantastic. Let's get started.
Okay, did we have any more housekeeping to do before we get started, Carrie?
No, I think we're good to go.
Okay, let's see. Should we switch the screen share to me then?
Yep, go ahead.
Okay, all right. Well, good morning, everyone. My name is Dr. Suzanne O'Connor. Thank you for being here on a Saturday morning. I do appreciate it. So today we are going to be talking about really how the opioid crisis is the next frontier for brain injury and how the two kind of mesh together. Just a quick disclaimer, this project is supported by the Brain Injury Alliance of Arizona. Let me go ahead and get my slides up for you, so we're not just watching me. There we go. Everybody see the slides? You want to give me a thumbs up? Good. Okay, great. All right. Go ahead and
we can see it, but it's not in presentation mode yet.
Gotcha. How are we doing now?
Perfecto.
Okay, great. All right. So, okay. So a few things we're going to go over today is looking at how exactly the opioid public health emergency statistics can be incorporated into your own knowledge base for you to use for your own lectures, or if you were working in a clinical facility to kind of explain to perhaps your own patients about how some of this really comes to be. I also want to relate to you about how to identify any relevant research concerning the prevalence of substance use and brain injury. Identify some potential barriers in the treatment for persons with traumatic brain injuries or acquired brain injuries and substance abuse clinics or mental health settings. And then we're going to learn how to administer a screening instrument for brain injury and how to make an appropriate referral to the Brain Injury Alliance of Arizona. And then finally, really, I want you to be able to use this information to create a deeper understanding about how the neurocognitive changes following a brain injury that information can be used to kind of modify your own treatments and maybe your materials for individuals with a history of brain injury to actually get better traction on the substance abuse treatment that you're applying. How did we get to this point of a public health crisis? Well, let's talk about that for a minute because we just want to do a little bit of background. There were actually 3 waves of opioid overdose deaths. And what we really want to kind of understand is how we got here. So looking at hang on, I'm going to use my annotate so you can actually see my mouse. Okay, so the first wave really started in the kind of 90s. And what we were looking at was an increase in the prescription of opioids that were given for all kinds of things: dental procedures, migraines, after surgical procedures, chronic pain disorders, epilepsy, ALS, even multiple sclerosis, and things of that nature. And it just kind of increased. So we were using them in a productive way, but this is where you see the increase in people having problems with developing addictive disorders following the use of prescriptions, okay? And then that first wave is really about prescriptions. Then the second rise, which started around 2010, was an increase in actually heroin overdose deaths. Now, notice that even though we're going to be talking about the treatment of how to be using the treatment of opioids and brain injury, largely the literature looks at the opioid crisis stem from how many deaths were occurring because of opioid use. And so another thing is we're going to be looking at is there's two waves, or three waves really with this. And part of that is it comes out of the prescription use, which we're seeing in wave one, but also that we're going to look at, then there was an illicit use that followed it, which we're really kind of seeing in wave two around 2010, excuse me. Another thing is we're going to be looking at is there's two waves. Then what we saw in wave three, approximately 2013, 2014, was an increase in synthetic opioid overdose deaths. So what does that really mean? The first wave, if we look at it, is deaths involving the prescription opioids that are either synthetic or semi-synthetic opioids, kind of like methadone. And then even though all these things have a poppy derivative for the natural opioids, synthetic opioids are entirely lab created. And that's where you get things like fentanyl and methadone. Semi-synthetics are opioids that are like morphine or codeine based. And the problem with the third wave is that some of those synthetic drugs are then also offshoots made in Mexico. And so illicit, not just illicit drugs, but things that look like prescriptions, but aren't, and are made with different types of drugs. And the fentanyl is not well controlled. Fentanyl was a drug probably you hear a lot about on the news these days, or those of you who are working in the industry kind of cringe when you hear it because you know it's about 10,000 times stronger than heroin is. I'm sorry, that's 50 times stronger than heroin is. And then things like carfentanil, which is an elephant tranquilizer, are things that are like 10,000 stronger than morphine. So these kind of drugs are really scary as they start to make it into the markets. And in response to that, what you started to see were a lot of advertisement and public health service announcements that were really trying to inform the public about how this was really happening, how much the opioid crisis was really becoming a major part of life. And I had even heard one of a local clinician here describe it as, look, having this many people die per day is like watching a 737 go down and nobody doing anything about it every day. And those kind of numbers are absolutely jarring, especially when you look at the increase, 68% of those deaths were from pharmaceutical related injuries or heroin related injuries. This piece is from the CDC. Here's another piece that's actually from Health and Human Services. This is opioid epidemic by the numbers from 2016 to 2017. These numbers are a little bit less, 130 people plus die per day, and over 2 million people are still addicted. And in case we think this number is decreasing, I want to assure you that's not. Just actually, I think today on NPR, there is something about the opioid crisis that we are still facing, even here in 2020, despite everything else that we're going through. And it wasn't just in major cities. Here's another piece that really highlights, okay, in the United States, of course, we're seeing a dramatic increase from numbers. These are the tan numbers are from 2016. Darker brown numbers are from 2000 to 2017. So it's looking at the increase. But what it's really showing you is a sharp increase in not just the large metro areas where we tend to think that these increases in use of opioids happen. It's also in these fringe areas. So for those of you who are here in the Valley of the Sun, we tend to think of these things happening in like maybe in downtown Phoenix. That's where you would see problems with heroin. But actually, it starts to spread out in fringe areas that are outside in kind of a more suburban area or medium metro area. So the surrounding areas like Tempe, Scottsdale, Chandler, Gilbert, Buckeye, and even smaller metro areas, micropolitan areas, and rural areas. This opioid crisis has reached to all facets of America. And even though we really see large problems in areas such as like Boston, Massachusetts has one of the highest rates of one of the opioid crises, what you also notice is that it truly is even in middle America and farming communities, it's everywhere. This is another kind of a glimpse just more at Arizona itself and how the increase in use of all opioids has continued over the years since 1999 to 2018. And we can also see that the use of synthetic opioids has significantly increased since about 2016. It's taking a major increase. Okay, so what did we look at then? What's happening? Those are some of the highlights of how the major organizations around the world are trying to inform you and everyone else about what's happening. So then in 2017, when overdose related deaths were 6 times higher than they were in 1999, there was finally a declaration. President Trump declared that opioid crisis is a national public health emergency. And what that did is it started to release some funds to start to combat this opioid crisis. And the 5 points of it were to, of course, better substance use disorder prevention, treatment, and recovery services, better data collection, better pain management that actually looks at how doctors are looking at pain, better targeting of overdose reversing drugs such as Narcan, and then just better research in general in all kinds of populations, including mental health communities and substance abuse clinics. And then in 2019, they continued, and I'll just go ahead and read you the quote here. The House and Senate reintroduced a bill that would invest $100 billion in federal funds over the next 10 years to better address the opioid overdose epidemic, which took almost 48,000 American lives in 2017. So this is the Comprehensive Addiction Resources Emergency, or the CARE Act, and includes provisions to strengthen the standards of recovery residences, establish new grant programs, and to help individuals living with addictions to find or maintain employment. This is going to be one of the major keys, and incentives for states to cover a full range of addiction services with their Medicaid programs, which is an interesting twist because in years past, and I'm not saying anything, I don't want to, get into a political campaign, but during the Reagan era, when we had the war on drugs, and a lot of these, the use of drugs became criminalized. So we were locking away a lot of people who maybe needed treatment more than punishment. That's debatable, but in the meantime, what you're looking at here is a kind of a switch in ideology to say, hey, we need to really look at these addiction services for people who are in Medicaid programs and how can we reach them and help them. So we're really looking at serving underserved population or economically challenged populations. Okay. And then what happened from there is, so they started to release this money and to really help fund programs such like this. But the major pieces of that go to areas like the Center for Disease Control and Prevention, which really targeted prescription drug use, and it's looking at it per state, prescription drug overdose, a little more data-driven and enhanced surveillance of that. Health and Resources Services Administration, that's really kind of looking at how to expand the access and quality to substance use and disorder and mental health services. I can't speak to other states right now, but I can tell you in the last 3 to 4 years, there has been a substantial increase in programs to directly address opioid use and detox centers. Then we're also looking at the behavioral workforce for education and training and enhancing the workforce for aftercare programs, which is huge. Again, this is a huge change in ideology. And also reaching out to more rural communities. Now, here in Arizona, what that looks like is looking out for maybe into tribal reservations, or also smaller communities that are in more outlying areas. We tend to have very condensed populations here in Arizona. And so being able to reach out into some of the more rural communities has been an important aspect of this. And then of course, SAMHSA, the Substance Abuse and Mental Health Services Administration, that really helped us look at medication assisted programs, and not just hitting everything with a methadone program, but also looking at other newer drugs like Suboxone, looking at state targeted response grants, and looking on how to partner with, create partnerships throughout the state and interstates, and then really helping first responders with how to get comprehensive addiction treatment education, and also how to use Narcan. Everybody okay? Stop for any questions? We're good? Okay. All right. Let's see. And again, as I had mentioned before, in case anybody thinks that this opioid crisis is not still going on during the COVID pandemic, I want to assure you that it still is. This report was from May 18th of 2020, and it's from the American Medical Association. And one of the things that we have been worried about in the field of mental health and addiction recovery and brain injury recovery and support is that the isolation that needs to occur during this pandemic also has some deleterious effects for what we're trying to promote. Now, I know the Brain Injury Alliance of Arizona has been just superb at reaching out and creating support groups on Zoom, making sure that people still have connections. And I know just kind of watching the American Psychological Association and some other listservs that I belong to for neuropsychology and rehabilitation psychology, that trying to make sure that people still feel connected has been a major target of what we're trying to accomplish, so people don't get the sense of isolation, so they don't become depressed, so they don't feel like they don't have anywhere to go. This is especially important for those who are looking to create a relapse prevention plan for opioid related recovery. And yet some states, as many as 20 states, this article points out, have actually reported increases in related to opioid related mortality. But with that note, I also have to say that there was a, and I'll just read you the quote that I took from, it was Fox 10 here in Phoenix. And it was saying from a local newscaster, it was, according to the numbers from the Arizona Department of Health Services, there were 270 overdoses in this state in April, and that's the lowest since it was 260 in December of 2018 for fentanyl overdoses, which is the deadliest of all of them. And so we're looking at, I guess that's a little bit of progress, we call it, maybe. But I want to give you kind of set the groundwork for all these numbers. And that's why I'm kind of giving you this information for those of you who don't work directly in this field about what we're actually facing, what we've been facing for the past 20 some odd years. But the fight against the opioid crisis still faces many challenges. And one of which is, how the opioid use disorder really correlates with brain injury and death. So, looking at what many neuropsychologists like myself look at as we call it the DSM manual, or it's the Diagnostic and Statistical Manual. We're on the 5th edition. And this is how we come up with criteria for mental health disorders or substance abuse disorders. So even though I use the term addiction, which is actually not more of a clinical term, we will talk about it, how we're basing these opioid use disorders. So people can use opioids and not have a problem with it. You can be prescribed it, and many doctors still do for all kinds of things. To have a hip replacement. If somebody has very painful dental procedure, it's still certain types of pain, it's still called for. And they're trying to look at how to solve that, how much, how frequently, and for how long you prescribe it. If someone uses an opioid-based prescription just for a little while, that's not really an opioid use disorder. It becomes an opioid use disorder when you're really seeing a clinically significant distress or impairment with at least 2 of these symptoms for a 12-month period. And to highlight that, this isn't all the criteria, but to highlight that, impaired control, misuse, right? Using somebody else's drugs, using more than you should, using an illegal substance, social impairment. That's a real key to any kind of disorder or use of any substance. Is it actually going to impair my functioning at work and school? Again, risky use, meeting the pharmacological criteria. That's really, excuse me, about kind of building up tolerance. And then there's a kind of a determination of severity, which also goes with the frequency of use and how much. Okay, so for those who are new to this area, what is an acquired brain injury? Damage to the brain that occurs after birth, okay? It's not the result of a congenital disease or a degenerative disease such as, let's say, Alzheimer's or Parkinson's, okay? And it can include a blunt trauma or a penetrating trauma to the head, which we would call a traumatic brain injury. It can be a stroke. It could be a hypoxic, which is lack of insufficient oxygen to the brain, or an anoxic, which is complete lack of oxygen to the brain. And those kind of injuries can result from things like heart attacks, drowning, and drug overdoses. So here's where we kind of come into play, connecting the two. Opioid use can be the cause of a traumatic brain injury, and it can be described as an acute poisoning to the body and result in excessive opioid intake. It is a serious condition and it can cause death. Largely what we see in an opioid overdose is it depresses the oxygen intake and circulation, and it results in an anoxic or hypoxic injury. And these types of injuries the first thing that gets treated really when the EMTs show up is hit it with an Narcan, stop the intake, and cut off how it's expressing into the brain to help somebody start breathing again. Long term, this can actually cause, depending on how long a person stops breathing, very similar to a drowning incident, this can cause long-term damage. And it can also impact things like decision-making and mainly memory. Okay, so according to the National Institute of Health, opioid overdoses resulted in over 47,000 deaths. You'll notice as we go through the slides that different facilities sometimes have different numbers. And I don't want that to be confusing for you. I just kind of wanted to give you a flavor of, look, depending on who's gaining these statistics, there can be different statistics out here, but they're relatively similar. So I don't put those up to make that confusing for you guys, but I do put those up to say, hey, sometimes it's a ballpark figure, okay? Now, other times is sometimes we have the opioid use disorder is an effect of the brain injury. So a lot of acquired brain injuries are frequently the result of, they can result in a lot of chronic pain, even weeks, months, or years. So after the injury, so when someone has an accident, a bicycling accident, a car accident, if you can think of the musculoskeletal injuries that go along with this type of pain, sometimes there's a craniotomy that comes with it. This is oftentimes when there will be a prescription for opioids. And as you can see, 70 to 80% of hospitalized patients are discharged from the hospital with an opioid prescription. 21 to 29% of Americans prescribed opioids go on to abuse them. And 8 to 12% of Americans prescribed opioids actually develop that opioid use disorder that we were describing before, okay, where it becomes like 12 months of problematic use. So what are some of the recommendations that we're looking at? I'm gonna keep moving one of these. Okay. So the opioid prevention and education programs. And this is where we were looking at SAMHSA had that one of the initiatives. Actually, many of the CDC is another one who also has the initiatives. And this is kind of what we're doing today. Put the information out there. Let's see how much we can prevent. Let's go in and talk to other doctors and clinicians about taking account for the increased risk factors of brain injury survivors and make extra efforts to reach out to them as well. And their families or caregivers. It's also imperative that these programs and their partners with other professionals work with survivors in order to create initiatives that effectively serve this population. Medical professionals and policymakers have to partner together to create guidelines that mitigate the risk of opioid addictions amongst brain injury survivors and provide potential alternative treatments for pain. And a lot of these pain centers are looking at things like mindfulness, cognitive behavioral therapies, acupuncture, massage as a way to potentially have other options. For substance abuse treatment facilities, the big piece is being mindful of the prevalence of brain injury, that it's already in their population, and make adequate efforts to screen. And that's really what we're going to talk about today, about incoming patients to really determine any past brain injury history. It's very likely that within a substance abuse treatment facility that you won't see someone with a history of severe brain injury, but a moderate or mild brain injury, you may be likely to see it. Now, if an individual has a history of a moderate brain injury, they're likely to be able to tell you about that. But sometimes individuals with a history of a more mild brain injury won't really identify with it, especially if it's more of a distant past occurrence. So brain injury survivors with an identified substance use disorder often have difficulty finding a facility that can help them while also working with their unique cognitive, behavioral, and emotional challenges. And this is something we're going to talk about in the coming slides, because it is crucial that facilities are available and staffed and that are trained to be able to meet these kind of needs. Sometimes it's very similar to having an individual who has maybe an intellectual disability when we're talking about cognition, or that has a mood disorder. Carrie and I have had several conversations about there are a lot of treatment facilities in the United States that pride themselves in being able to treat dual diagnosis, which for those who are in common with this phrase, it's an individual who has a substance abuse history, but also has a history of perhaps like a mood disorder like depression or anxiety, which is very common because individuals with a mood disorder will start to self-medicate. And so being able to look at both of those issues becomes definitely important. But what we sometimes don't see is how many people actually have a history of a brain injury goes unnoticed. And it could look like a mood disorder. It could look like a developmental disorder. It could look like a little bit of both, when in fact, it may actually be a history of brain injury. Okay, so how can someone tell if a substance abuse client has an ABI or TBI, again, acquired brain injury or traumatic brain injury? Well, again, as we mentioned, a prior TBI is pretty common in individuals with substance abuse treatment. And you may want to know how common it is. Well, we're going to go through a few, this is some of the research, some of the literature to help you with that. In a review of 5 studies of people in substance abuse treatments programs, it's the estimates for a prior history of traumatic brain injury ranged from 38% to 63%. And in another study of 7,784 adults in a state-funded substance abuse treatment program, almost 1/3 or 33% of persons assessed at intake reported a history of 1 or more head injuries for which they lost conscious or were hospitalized at least 1 night. That's pretty significant. If you are an individual who is a professional working in a substance abuse treatment program now, and you're thinking about, could I actually have 30 to 60% of individuals in my program that may have a history of brain injury? That can be almost jarring. And maybe what can the thoughts start to be, is there a way to better reach those individuals? And maybe something else that would be helpful for you to know is that I work in neurorehabilitation. I think I forgot to say that today, but I actually am a faculty neuropsychologist at Barrow Neurological Institute at the Center for Transitional Neurorehabilitation. I also worked for quite a few years at Rehab Without Walls Neurosolutions as a neuropsychologist, also in neurorehabilitation. And I can tell you that in treating my patients with a history of either traumatic brain injury or acquired brain injury, 30 to 50% of my patients at any given time had a history of substance abuse disorder. So what are some of the common effects of traumatic brain injury? And I would like to present this to you guys so you know kind of what it looks like, because some of these physical and cognitive, even emotional changes that come after a brain injury can look very similar to a mood disorder or, like I said, an intellectual disorder. So some of the physical effects that come with it are feeling dizzy, fatigued, headache, visual deficits, and that can be field cuts or neglect sometimes. Can be auditory impairments, seizure disorders, and sleep disturbance is a very big problem after traumatic brain injury. And that leads people to seek out using drugs or alcohol. Cognitive effects can include communication issues, any type of aphasia, both receptive and communicative, poor concentration, being disoriented, sometimes you know who you are and where you are, but not always maybe why. Memory problems, just poor organizational skills. The person who always has the binder with all the papers sticking out of it, that might be them. Slower processing speed, difficulty with poor initiative. And I really want to talk about that a little bit later, but I want to tell you that initiation is different than motivation. And although sometimes we would take the two to be similar, in the world of brain injury, it's not. It's not an individual is not motivated. They're having difficulty initiating what they're doing. And that can actually stem from brain injury. And it can lead to things like poor follow through. So if you're giving homework assignments, that might be a problem. Poor judgment, poor problem solving skills, and then emotional changes, right? Increases in anger, anxiety, depression. And then there can be something called organic unawareness. And this is unlike denial, which we do also, you can also see with a brain injury. But unlike denial, this is a true unknowing and anosognosia, if you will, about what's going on with them. They just don't even recognize that there's a problem. And it's not denial, although it could be a combination. Confabulation is kind of a fancy word for making up stories. But it's not just kind of lying. It is in the truest sense, it's an individual is making up a story that they're trying to make sense of the world around them. For instance, I'll give you a real quick example. I once, during a family meeting to give feedback to an individual who had suffered a very significant stroke, and his family members, some of them on the phone, some of them in the room, and then of course the treatment team, which usually consists of physical therapists, occupational therapists, speech therapists. He had been a very high-powered gentleman, ran a construction and he thought that we were at a board meeting. He thought that he was selling me his team, his services. So he became very confused when when the team and I started to give him feedback about the evaluation that he had just been through, which he did not remember. Confabulation usually comes with really significant memory impairments.
Dr. O'Connor, this is Carrie. If I can really quick, from Brain Injury Alliance's perspective, one of our times we helped somebody with confabulation, a school nurse called and they had it was a small school, so they knew most of the students, knew their behaviors, knew them since they were in kindergarten. They noticed a student had multiple sports concussions and seemed to be making up things that were easily disproven and didn't have they weren't very significant lies, but they still were going to fall under having severe academic dishonesty penalties. And so they called just wondering if there was any way these two things could be related. And absolutely. So to me, that really told me, one, in the teenage years where it's very hard to distinguish sometimes with those mild brain injuries, what's being, in the job description of being a teenager and what's a brain injury. And also that there can be some really real world consequences for behaviors and action after brain injury, even if the individual doesn't understand.
Absolutely. And I'm glad you brought that up, Carrie, because we also want to impress upon you that this is not just with adults. It's definitely going to be with children too, and a wide range of individuals. Concussions, that's the whole other topic. And I know that the Brain Injury Alliance, I think, Carrie, you actually have some very specialty topics and other speakers that cover that, but very important topic. Okay, so the next frontier for the opioid crisis, in my opinion, from my lens, is how to identify individuals with brain injury in the substance abuse population. So we're going to talk about now how to screen for brain injury. There are several different types of screeners that you can use, but this one is called the HELPS, and it is for a brain injury screening tool. And the reason that we picked this is, one, it does have, in the scientific community, good sensitivity and specificity, but it's also very efficient. As individuals who are working in the healthcare field, those of you who are actually working in substance abuse treatment places, I understand that you don't have a lot of time to put in one more tool. However, there are a few additional questions that could be very helpful for most of us who are doing the intakes and saying, have you ever hit your head? And we just go right through it, and we don't ask a lot of questions. Probably the same way that some of us in neuropsychology probably should ask more questions about addiction and actually quantify better about how many beers that is and how large the beer is. I learned that early on in my training. Asking just a few more questions about brain injury could really help specify this. So what do we have here? Short screener, very efficient. One question, the very first one. Have you ever hit your head or been hit in the head? So rather than have you had a brain injury, just have you ever been hit in the head? And you might want to prompt a little bit about how did it occur at any age? Any vehicle accidents or falls, or as Carrie mentioned, anything with sports, a history of sports. Sometimes we have, individuals who have had a long history of being in sports, have had many concussions, and that's important to know. Again, maybe this is also part of a screen for domestic violence or child abuse. You want to know if someone's had a history actually of shaken baby syndrome. That's going to be important for you to know. Question 2, were they ever seen in the emergency room, hospital, or by a doctor because of injury? A lot of people who have a mild brain injury or maybe concussion will not actually go to the emergency room if they feel okay, but some will and get checked out right away. So if you go into urgent care and they're like, yeah, you probably got a concussion, even if you got knocked out for 30 seconds, that's still a mild traumatic brain injury. And if they say it's a concussion, that's kind of what you want to have on that list. For our veterans and who have been in blast zones, you definitely want to know if there's been a time when you maybe got knocked out. It's important. So asking those questions, if they were seen by a medic at that time, again, part of the list. L, did you ever lose consciousness or experience a period of being dazed or confused because of the injury to the head? And I really like this question because a lot of people might not lose consciousness, but they may feel a little dazed. I myself have had several moments where I've gotten hit in the head for different things. And I didn't actually lose consciousness, but it would knock me for a loop, or at least twice that I can recall. It's kind of knocked me to my knees. You have the Cherokee, and it had this door and the shocks on it. It started to go out. So you're unloading it the back, for those of you who have SUVs, and then you got to stand up, but the doors come down and you stand up at full speed and boom, and it just kind of knocks you to your knees for a minute. I see some people nodding going, yes, I've been there. So those of us with minivans, yep. same thing. So it's important to know that sometimes not fully losing consciousness, but feeling dazed can be a signal. And another important piece, P. Okay, so were there any problems in your life since you hit your head? Now, a lot of people will say no. Many of us brushed it off. We rested for a day or two and there's been no problem. But looking at what we know now about things like post-concussion syndrome is that for at least 20% of the population who receives concussion, they can have ongoing symptoms. And we tend to, as Americans, we're the pull yourself up by your bootstraps, keep on going, dust it off, and go on with your day. But for, again, a small percentage of the population, we can have ongoing symptoms like headaches, dizziness, just kind of feeling more agitated, anxiety, depression, difficulty concentrating, difficulty with problem solving, maybe our performance drops at work and school, changes in relationship. And as you can see, some of these things like increases in not feeling well, either emotionally and physically or both, can really start to interfere with our jobs and relationships with others. And we may even start to show poor judgment, become fired or arrested. Okay, and was there any significant sickness caused by the physical blow? Now, again, as I said before, some people will really understand that, following something such as a traumatic brain injury, you've got this big diagnosis and you've been, through a treatment, either inpatient or inpatient and outpatient. Some people will know that West Nile virus actually can cause significant difficulties, cognitive changes afterwards, problem with word finding difficulties, memory, actually many difficulties. Persons with seizures, history of stroke, history of brain tumor, those can all be problems. Okay, now this particular model shows you at the bottom. So when is this? If somebody answers yes to 3 of these items, especially H, E, and S, that's probably there was a period of loss of consciousness or altered consciousness for E or L. And there's a presence of 2 or more of these problems under P, that's probably a good time to maybe start thinking about making a referral. Okay, so I'm not actually asking you to diagnose, oh my gosh, this person has a brain injury. That seems like a little much, but there may be a few more questions that may need to start coming up. So as you're moving through the helps and asking these questions, right? Have you ever been hit in the head? Have you ever been in the emergency room? Have you ever lost consciousness or have altered consciousness? Did you have any problems in your daily life afterwards? Or were there any other sicknesses or physical injuries? You may start formulating questions. Do I need to make a referral? Do I need to ask this person, hey, did you ever get diagnosed with the concussion or traumatic brain injury? And if you have a traumatic brain injury, maybe was there any imaging? So here's another model. This is the Ohio State University TBI identification method. For those of you who are very into asking more questions, have more time for an initial evaluation, this is another nice piece. But as you'll notice, if we look down here in step 1, the questions are very similar. Again, in your lifetime, number 1, have you ever been hospitalized or treated in the emergency room? Number 2, have you ever injured your head or neck in a car accident or a crash from a bicycle, motorcycle, or ATV accident? Number 3, have you ever injured your head from a fall? And what you'll notice is step 1 is then corresponding. You're going to write the cause down of these questions, right, into the boxes below. And then you'll start to ask questions for, section 2, excuse me, about, was there any loss of consciousness? Did you feel dazed? Did you feel, were there any other issues at that time? And how old were you when the incident occurred? And then, of course, area 3 which is looking at the questions about identifying the history if there's been multiple traumatic cause of them, and then how severe. Maybe more information than you need at that time, which is why the help is nice and efficient. This is also a brief screening measure, but can take just a little bit longer to fill out. So here's your next question. I think my client might have a brain injury, so what do I do now? Again, maybe asking if there's more records available, if there's neuroimaging, if there was some neuropsychological testing, because what you really want to know is, okay, so they're past the injury, they're past the critical point. Where does that leave them? And what kind of cognitive impairments might they have that you might want to know about, so you can enable substance abuse providers to modify approaches to treatment and better meet the client's learning style. And if you're just not sure, refer. Always refer. And I'm sure Carrie can speak more to this, but contacting the Brain Injury Alliance of Arizona for more resources can be so helpful. And I know she's going to speak about this again in a moment, but refer. Even if it turns out that it's not a brain injury, that's okay. That's not a problem, because at least we can eliminate that. But getting them into the system then can really be so helpful and start the process of, for those individuals who don't understand maybe why they've been through substance abuse treatment programs before and it's not working for them, or start to feel hopeless, like I can't do this. This can really be the game changer, because we can get the supports around them that they really need. And you can find methods for better reaching them and helping with their relapse plans. Just a little bit more information about sometimes who we're seeing. In a study from 2007 that was published in 2017, 80% of individuals in a community mental health center screened positive for a traumatic brain injury. 80%, at least a mild traumatic brain injury. And 25% of those had reported at least one moderate to severe traumatic brain injury. That's a lot of individuals who maybe we overlooked. If we didn't know that they actually had the presence of something that was organic, or maybe our approach to it could change about how we're reaching out to these people. Traumatic brain injuries are common, and especially in the substance use disorder population. And failure to properly identify these individuals seeking the treatment can lead to a lot of misdiagnoses, high dropout rates, and inappropriate applications for treatments. Your facility actually may be the first to catch a client that has this co-occurring disorder and make a real difference in this person. So some suggestions for substance abuse treatment providers in working with individuals with acquired brain injuries are to coordinate with other providers of care, promote an expectation for rehabilitation from the drug use and the brain injury. We are often in brain injury rehabilitation, we're incorporating all kinds of compensatory strategies and use of organization and memory tools, and ways to help kind of moderate and emotionally regulate. And I know you guys are doing the same thing. Again, I forgot to mention my background when we started, but I also worked for the International Institute for Trauma and Addiction Professionals for 9 years. So I know the good work that you guys are doing. And I know that you, many of you, no matter what the theoretical background, are really looking at an individual from a holistic model, right? Trying to reach them at, the behaviors, the emotions, how they're doing physically. And so working hand in hand with some of their other providers may be such a wonderful opportunity. encouraging support groups on both sides, definitely from one of the many that the Brain Injury Alliance of Arizona provides, but also, maybe the 12 steps or smart recovery groups that they have around the country can be an amazing first step. Lots of psychoeducation. It does take a repetition of the education. Some of the more evidence-based theories obviously are going to be cognitive behavioral therapy, motivational interviewing, definitely supportive stress management and healthy coping skills. Because not only are you looking at an individual who, again, very different from someone who is born with brain changes, the individual who has the brain injury probably coped different before. And if one of their coping mechanisms then became use of drugs or alcohol, in this case, opioids, we're really looking at someone who needs to find a way to, one, cope without the substance, and also has to find a new way to cope because it may have changed since the brain injury. And the way they did things before might not work for them now. And I think substance abuse populations do this, a really good job at this, is helping individuals find new hobbies, do new things, go for a walk, find a new outlet, find a new group of friends, and identifying good supports and bad influences, which unfortunately can actually be family and friends. So, and very similar to substance abuse treatment and brain injury recovery, very similar is repeat, 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 over and over again. So some of the things that we can do to help that process is sometimes just looking at the time. I want to be sensitive that you're spending your Saturday morning with me, is ask how well the person reads or writes. We really want to evaluate this in samples. And I say this as an individual who actually, I used to help design materials for several of the inpatient programs across the country for behavioral addictions. And I have to say that a large amount of materials sometimes for an individual with a brain injury, even a mild traumatic brain injury, can be overwhelming. If they have visual difficulties, it can be overwhelming. If they have slowed processing speed, it can be too much. And so really looking at the way that they read and write and can be important to their intake and understanding how they're actually comprehending the information, the great information that you're giving them. Also evaluating how well they comprehend written and spoken language. I am from the East Coast originally. I can be a fast talker, and I have really had to learn over the years how to be mindful and slow it down a little bit for my patients with brain injuries. Not all of them, but some of them. They definitely need you to go a little bit slower, use more words more concisely. They don't need a lot of information, they need pertinence. So, and if the individual is not able to speak, that has a history of aphasia, maybe incorporating alternative use of measures. We use the iPad a lot, but also writing or gestures can be very helpful. Observing someone's attention span. This is one of those areas that can be really misconstrued while in a substance abuse treatment facility. I see, people looking around, not being able to, attend to maybe some of the group therapies that are going on. And this can seem like maybe a temporary behavior during early recovery. And yet for an individual with brain injury, this may be more of a permanent occurrence. And asking about a person's capacity for new learning. definitely sometimes, and especially with this very small population, but with this population, we're looking at an individual with a history of, let's say, an opioid overdose. And I have treated this population, and they oftentimes have very significant memory issues. And it's short-term memory. They know about what happened to them, you know, in their childhood, and they know what happened before the injury, but learning new information can be considerably difficult. So really, it's going to be about trying to find ways that you can maybe give them written and spoken information, and how can we repeat to really determine what's going to be optimal for them. And how can the substance abuse provider, again, just kind of more points about how you can really assist the individual to compensate for a unique learning style. And again, it's modified written material, make it more concise, paraphrase, use more concrete examples, allow the individual to take notes, is very reinforcing. Actually, in psychology or neuropsychology, we call that priming. And it helps to reinforce if they can. They can also review and recall it later. Encourage elements that really reinforce organization. Use of a calendar and a planner. Sometimes they have pocket versions that are easy to use. A lot of us now use our phones to set alarms to remind us that we have homework assignments and things like that. After group sessions, really being able to meet with the individual kind of to reinforce those key points, maybe, and to write them down into the notebook can be very helpful. Providing assistance with any homework, especially if they're big flow sheets. I know some of the flow sheets that we used to make for the treatment centers that I worked with back in the day, we'd have these big ledger type of sheets, and they would have a lot of information that can be overwhelming sometimes for an individual with a brain injury, but you can help them work through it. And enlist family and friends who are supportive. And don't take for granted that the idea is going to generalize. It takes a lot of reinforcement. And again, repeat, review, rehearse, repeat, review, rehearse. It's kind of the model. I know it is for substance abuse treatment, but it also is for brain injury. So putting those two together, it's going to take just a little bit of extra effort, but so worth it.
And Dr. O'Connor, this is Carrie. In a moment, we're going to talk about the free support from the Brain Injury Alliance. So this will kind of come together. We have a licensed clinical social worker, Maddie Cummins, who will work with families. We have family peer support, and we even provide a lot of the things like calendars, organizers. So it is as easy as possible for you to assist your clients that may have brain injury. So we have an entire suite of wraparound services that I'll talk about in a moment. Thank you.
Absolutely, good point. Just a few words about behaviors that you might see when you're working with an individual with a history of brain injury too, is that sometimes their behaviors can be inappropriate, and you can't assume that that individual knows. Again, that organic awareness, an awareness that I was talking about before, that anosognosia is the technical term for it, is it's truly being unaware of maybe social cues in the environment. And so you need to provide the individual appropriate but assertive, straightforward feedback about when the behaviors are inappropriate, because it's actually a learning of social pragmatics for them. And then we definitely work on it when an individual is in, let's say, an inpatient or an outpatient neurorehabilitation program. Again, the generalization takes practice, and it takes the reinforcement and help of places like the Brain Injury Alliance support groups, friends and family, and it will also take your need for reinforcement. And truly redirecting any kind of tangential or excessive speech. Again, they may not truly be aware of how outside of the bounds it's becoming, or if it's disruptive to a group. And usually you can work with an individual to say kind of a predetermined signal, you know, for those of you who are old enough, like a Carol Burnett on the ear thing, to let somebody know with a nonverbal signal when they're in a group that, hey, you need to tamp it down. But they do need that feedback. And you can find small but effective ways to do it. A few words, just kind of making inferences. I talked earlier about the difference between initiation and motivation. And this is, again, not to presume that non-compliance is actually a lack of motivation or resistance. Look into it, check it out. Many, especially traumatic injuries, terrible rollover type of injuries, can really affect these kind of deep centers in the brain that are responsible for things like circadian rhythms and that tonic arousal, which is somebody's kind of alertness and their ability to, and this is from the frontal lobes too, to actually initiate a task, just to begin. It's not that they don't want to, it's not a motivation issue. It's truly, it's how the brain says, okay, now start. And be aware that there can be a large difference in that. And it's also going to show up in not just their ability to start, but like their follow through on their homework. Be aware that their unawareness of their deficits can arise in any situation. And it really kind of results in very specific damage to the brain. And again, it's not always denial, as we were talking about before. The two can go hand in hand. You can't have both. It's truly a separate issue. And though we do work on it, it kind of resurfaces for them in different situations. So when an individual, if a survivor is in a novel situation, they might not be aware that of the changes or their behavior changes. Confrontation, well, I think this pretty much happens for everybody, but definitely for individuals with brain injuries, it just kind of, confrontation just shuts down their thinking, especially if they're kind of rigid, if they're kind of black and white with some things. We call that cognitive flexibility. They may not have that as much. We definitely see this in substance abuse treatment centers that I've worked in. But you have to kind of roll with the resistance in a little bit of a different way. So approaching it definitely with an assertive manner is appropriate. And talking with the individual one-on-one about how can we take a different person's perspective, or why another theory may be important, or another way of doing things may be important. If you can, and I know every treatment center, whether it's brain injury related or substance abuse or both, has their own rules, but before you discharge for noncompliance, follow through, please. Find out why the person is a no-show or isn't following through, and is there another way that you can really kind of help them get back on track. It may have nothing to do with the substance abuse, and it may have everything to do with the type of brain injury that they've had. So I want to, last time I really ran over and I didn't have time for a lot of times for questions. I really want to leave some time for Carrie to talk about more about how the Brain Injury Alliance can really help you and incorporate some of the materials that they have, and any questions that you might have for me. Well, we had quite a few questions, and I'm sorry I couldn't see that when my screen was popped up the way it was before. So let's take a look. How Parents of Addicted Loved Ones organization continues with Zoom groups to help families. That's great. And I hope everybody can see these. Could traumatic birth contribute to brain injury? Yes. Can you say, Bernadette, can you say more about that?
Okay, I'm a mother of a survivor, but that's not the one that's addicted to drugs. My older son, he's followed a plan, but I remember when he was born, it was a terrible birth. You know, it was very traumatic for both of us. And when I didn't think about it before, but when they brought him to me, he would always be asleep. I'd have to coax him to eat, and then he was slow in the usual things like crawling, and talking. You couldn't understand him, and he was slow in that. But of course, I never gave it any thought because he was brilliant in school. I mean, brilliant. He has completed a college degree and he's board certified in a medical profession. But he lost all of that when his addiction just spiraled to a, you know. But the more I listen to these brain injury things, my husband's a survivor. That's how we met, through the Brain Injury Association. And then, of course, I have a traumatic brain injured son. But so I try to keep a balance, but the addicted one just threw me totally off. And when you just mentioned that, previous injuries, I just started thinking about how I noticed things in his in the beginning, but I never ever thought anything about it because he was the firstborn. You know, I didn't know any different. That's why I asked.
I mean, certainly a traumatic brain injury can happen during a birth. And, as we know, I mean, I'm not a medical doctor, but, there are certain things that can take place during birth sometimes that can make it difficult, especially like when the cord is wrapped around the neck. I know the doctors are working very fast to get to the baby. And so the proper oxygen flow can start. So the question is, the possibility, yes. Could it almost look like a development thing? If, you kind of, there's a range of when children learn how to do things, of course, that, and some are quicker to walk and talk and some are slower. And then ultimately it sounds like he did very well. So I would be hesitant, but there's always, you can make a referral.
I mean, we're always looking for answers.
Yeah, we are. It's so true.
Thank you.
Yeah, absolutely. Okay, Katie, I've heard that Suboxone is good and helpful for recovery. Is this true, or more prone to addiction? So right now, Katie, it is one of the major methods and that I'm aware of that they are using for people for detox programs, because it is safer than, of course, the other opioids that individuals are on. Does it lead to other addictions? So I think this is my clinical opinion. Suboxone is a good drug to start with. I think that, like anything that we do, there is absolutely room for the use of drugs. And I think there's also room for the treatment of therapy. And I think that the research currently shows that the best recovery comes from a combination of drugs and therapy. It definitely shows it for mood disorders. It certainly shows it for the treatment of other drugs recovery. not necessarily Suboxone, but I don't think it makes you more prone to addiction, but I think long-term use is not what is recommended, even though I do see that people end up using it long-term. But I think it's a good stepping stone. Did that answer the question?
Dr. O'Connor, I'm going to go through a little bit of our services real quick, and then we'll circle back around to the Q&A.
Yeah, please do.
Fantastic. So this is just a little bit of our services and how they tie together with hopefully your new awareness about addiction and brain injury. If you could, I'd like to know how common you think brain injury is. How many brain injuries per day do you think there are in the United States? If you could put that into the chat feature. Hopefully one of your takeaways from today is how common brain injury is. There's a traumatic brain injury every 23 seconds in the United States. And remember, those are of varying degrees. Most people will recover fully and on their own from things like mild concussions. When we talk in the community, it's our goal to introduce the services of the Brain Injury Alliance and really to talk about our trainings, such as the one you attended today, and understand the need. All of these ladies here have brain injury. So we really try to impress upon professionals that brain injury looks like you, it looks like me, it can happen to anyone at any time. We are Brain Injury Alliance. If you aren't familiar with us, we're a statewide nonprofit. We serve all types of brain injury. Our services are complimentary. There's no charge. You can call, text, email, even reach out on social media and talk to our certified brain injury specialist. So that's our staff has a specific credential to work with people who have brain injury. You don't need a diagnosis. Diagnosis sometimes can be very hard to get with brain injury. Sometimes. Danielle, who we showed you right here, down in the lower left, she had a training accident in the Army, stepped in someone's boot while she was running, fell, hit her head. Nothing showed up on an MRI that would indicate brain injury, but she has lost a lot of her childhood memories. She can't remember summer vacations. She can't remember who she went to prom with, but on an MRI, she looks just fine. That's why Dr. O'Connor said, refer, refer, refer. Our services are free. We'll direct people to somewhere else if they need to go somewhere else along the bus line. We also have Spanish-speaking staff. We also have resources for caregivers. So sometimes those with brain injury don't have awareness of their brain injury or don't want help themselves. We work with caregivers. When we say we serve all types of brain injury, both traumatic and non-traumatic, a lot of times what gets counted and shows up in the data is those traumatic brain injuries. Motor vehicle crashes are going to be your number one reported cause of traumatic brain injury. Things like football or sports are really well known perhaps as causing brain injury, but there's a lot of different ways that your clients and the people that you work with and see in the community are going to come in. We really, through this training today and other things, want to bring attention to those non-traumatic brain injuries, infections like the encephalitis that Dr. O'Connor mentioned, stroke, and also from overdose, near fatal overdose. A lot of people are having those routine falls, slips, falls. These are a lot of our clients, those home accidents. Again, things sometimes that cause a brain injury are not dramatic. It's those everyday slips and falls from household chores. You can refer, if you are a clinician, you can refer directly to the Brain Injury Alliance and we will reach out to the family. This makes it a lot easier for families that are particularly overwhelmed at the start of a medical treatment process for brain injury. We will work with them and chunk things out so that we have certain information ready when someone is released from the hospital. We have certain information when someone's ready to go to work. And we're also helping people find those specialists. We're helping them to get to Dr. O'Connor at Barrow and just get different places. Prior to COVID, we would have been co-located with Dr. Cardenas, who's a neurologist, at Banner TBI Clinic with Dr. Crane, at different military bases and schools. So we would have been co-located. You can refer. We are just finishing up an electronic referral as well. And just to shout out that we do work with families. We work a lot with families. So this is an example of a young woman with brain injury. Her husband puts a postcard up on the wall to make sure that she remembers it's wet or icy outside. So those families are really helpful in establishing routines and support for those who have brain injury. Prior to COVID, when we did work in the community, I reminded people that particularly those at ASU, we do a lot of trainings for ASU police officers. People out of their routines need our support and help more than ever. So you might have a teenager who had multiple concussions in sports or car accidents in high school that did very well because they had a structured household and a structured routine. Well, what happens when mom or dad drops them off at college? That routine goes away overnight. And you can see different deficits emerge, different things need support. Now, with COVID going on, we're all out of our routine. So I don't know if that would be as relevant today. So we, using our website, we have hundreds of vetted neuro referrals. So if you were to be suggested to go to a neuropsychological assessment, we would have information that you can pull up on our website on what that is, how to prepare for it, how to find a provider, and all of that information is available for families or professionals. This is under construction right now. We took our time at home to clean up a little. What Brain Injury Alliance is really about is supporting life after brain injury, education, support groups. We even have limited financial assistance, rent, utilities. We have survivors that we work with that know that they're going to have perhaps a follow-up surgery for their brain injury. They know that they're not going to be able to work next month, or it's not safe for them to work overtime. And so we are able to, in a limited capacity, help them with rent, utilities, pet care. All of those are from private donations. And so you just need to work with our resource facilitation team on that. But we're very happy for the people that we've been able to keep going and that are reaching out to us before things are at a critical point. A lot of the things we do also is work with professionals to help them really identify and serve the vulnerable, those populations who are more vulnerable to brain injury. We know that in like kiddos who have been engaged in foster care, veterans coming back with those blast injuries, formerly incarcerated, chronically homeless, that brain injury is going to present there more than the general population. So if you work with a population that fits into that vulnerable category, we really want to partner with you and help you provide excellent services. Just a reminder, this is the anniversary of the ADA. So we as professionals and community members really need to be cognizant on what we can do to help individuals. We aren't too far away from a time when the ADA was signed and there really weren't even rights, specific rights for the disabled. And so to be working with brain injury and an invisible disability, we really all need to be cognizant on how we can help individuals in our community thrive with those invisible disabilities as well. So happy almost birthday to the ADA, July 26th, 1990, George H.W. Bush signing it there. We also provide a lot of events. We're doing a lot of things virtual. This is pre-COVID. We actually took survivors who were artists. They were artists first and also survivors to DES, so Department of Economic Security, so that people who made decisions on paper about those with brain injury could meet them, interact with them, and tell their story. So that's kind of the power of us together as a community. Specific to opioid, we have an opioid response team. We have a veteran navigator, family support, and also an domestic or an interpersonal violence liaison. This has been an incredible, challenging time quarantine has for those financial stress, emotional stress. We're seeing more violence than ever, and we know that that can include head injury. So we have someone who specifically works with shelters. We have transportation passes, just a lot. Please feel free to reach out to us if you have any more questions or want a presentation on that specifically. And just a note about COVID-19 and our services, we are continuing virtually. We are busier than ever. I think on the first day of the shutdown, I got a call in the office. Someone was being discharged from the hospital. They needed a rehab in, I think it was in Flagstaff or Tucson. So just in addition to us really understanding the neurological implications of COVID, all of the normal services are still needed. People are still being discharged. They're being in accidents. They're having strokes. So really, our work continues. So I will throw it back to Dr. O'Connor for questions. And I just really thank you for your interest in brain injury and opioid use.
Thank you, Carrie. The information is so important, and I'm glad you're all here, and I hope this information is valuable to you today. I'll just answer a few more questions. Looks like Facebook Live doesn't have any questions right now. I had a few more questions on the chat here. One was from Tim about, does marijuana have a role, positive or negative, in persons with TBI? It's kind of a double-edged question. The research suggests there are some positives and negatives to it. I am working with an individual, and it's usually post-acute hospitalization or post-inpatient, which means I work with people who are also through a vocational rehab program. I usually don't recommend it, but I know that it has been, CBD oils have been very helpful for individuals. Here in Arizona, medical marijuana is legal. And so we look at it as working kind of with the doctors about what your needs are and how to best manage that. I can tell you in my research of marijuana and other drugs, but particularly with marijuana, when an individual is intoxicated, it makes learning impaired. It makes learning more difficult. So I understand the need to try to kind of control things like anxiety and depression or agitation that sometimes come with a traumatic brain injury. The cognitive effects of marijuana can impact in a negative way as well, especially cognitively, even though they may be helping on an emotional level. So it's not the first line of defense, I would say, but the literature would suggest that it can be both helpful and harmful. So I'm sorry, I'm not going to give you a straight answer there, Tim, but that's probably the best answer I can give you at this time. Some more issues. Okay, thank you for sharing. I know some of you are sharing that you've had experiences having some motor vehicle accidents or MVAs in the past, maybe one large one and some smaller ones. And another of you is also sharing with a group that you were diagnosed with a TBI in 2014, which really had affected you and had a workplace accident, and finally got tapered off of Oxycontin. Good job. That's great. I'm so glad to hear that, because it is a difficult fight. And I applaud you for those efforts and getting then tapered down off of the oxycodone. It does take a lot of work. There is one of the unfortunate things about some of the societal ways that we're living today is that we're kind of a microwave generation. We want it done. We want to take the pill. We want the magic bullet. We want it to be done. But the truth is that for real success in both brain injury recovery and substance abuse recovery, and any real change, I say, that you want to make in your life, it takes time. It takes practice. It takes good supports. It takes challenging unhealthy coping strategies, whether that's using heroin or overeating banana nut muffins. It takes practice, and you want to have good people around you and good supports. And the other thing I think that we have a tendency to do is feel like we have to do it all on our own, or there's a lot of shame or guilt about, God, how did I get here? With years being on pain medications. And I don't think there's any shame in it. I think that the real shame is that when we don't reach out. when we are isolated and we feel alone, and there is so much support around us, like the Brain Injury Alliance of Arizona. That's why we're all here. That's why I'm here. People like me are here. People like Carrie and Kristen and you know, all of us, is because we want to help. We know the situation is difficult and sometimes dire, and you're not alone.
Well, I wondered how much you were, if you were doing anything that looked at physician prescriptions for pain meds versus the addicts. I know I was dependent on those meds, but I wasn't an addict.
Mm-hmm.
So I just wondered if you know of any data out there concerning that.
I do. I don't have it right in front of me, but I can tell you that the Joint Commission, which is an accrediting body for hospitals.
Yeah, I used to be a nurse.
Oh, great. Okay. Okay. So then, you know, they are very adamant right now. And I was just taking, it was funny, I was just taking a course the other day, one of those kind of onboarding courses that you have to take. And it was about really understanding what prescriptions we're giving and why. And about the importance of making sure that we are giving the appropriate prescriptions. And even though opioids seem like the right drug, is it always? And yes, it is telling physicians and allied health professionals like you and I to really take into account having conversations with the patient, definitely being more client-centered, patient-centered, and looking at how much of the medications are they taking. Again, like you said, we sometimes become dependent on the medication to control the pain. That doesn't mean that we have, we use the term addiction really when it looks like it's becoming problematic, right? When we're losing our job, when we're, can't stop fighting with the spouse, if we even still have one, things like that, when it's very out of control. But yeah, I mean, there is definitely a push by the CDC, by the World Health Organization, by SAMHSA, to really make allied health professionals like you and I and physicians, DOs, and MDs look more at how they're prescribing, what they're prescribing, and how long they're prescribing, and what other methods of pain management can be offered.
And when you were talking about another patient that you said didn't have any changes on her MRI, that's when I would complain something's wrong with my brain after the MVA in 2008. That's all they did. They did an MRI, and then I just kept complaining. So then after a while, they did another one. Both were negative, but nobody, and I just at that time couldn't think of a neuro consult. And how easy is that for me to think of now? But back then, so it was undiagnosed for 6 years.
Wow.
And so, I mean, that's kind of huge.
Yeah.
So, anyways, I just wanted to, this is the first time I made it on and was able to talk. So after, I think 4 Zoom meetings. So yay for me.
Well, I'm glad you're here, and I appreciate you sharing your story with us, because that's exactly the kind of story that we're talking about, the unknowns, and again, those the neuroimaging that doesn't show up It doesn't mean that there's not something wrong. It doesn't mean that's where you're going to see a lot more of that, I think, in the coming years, those post-concussion syndrome. And I think what happens to individuals over time is that when it goes unconfirmed, that just kind of it has this positive feedback loop about what's wrong with me, why can't anybody find something, I know something's changed. And you know, I appreciate your vulnerability and coming forward and sharing.
Oh, you know, I'm, as you can tell, I share openly because I think my next chapter, it's not going back into nursing, is to do some kind of advocacy work. So, but I got to work on some other things first, but.
Good for you. I fully support that. That's awesome.
Yeah.
Great.
Thanks so much. You were, gave a great talk today.
Thank you. Thank you. I appreciate that. Let's see. I think we got everybody else's questions wrapped up. Carrie has left us kind of just with a little more information for neurological outcomes for COVID survivors next week. There's another link on the Brain Injury Alliance of Arizona, so biaaz.org. Also our staff will also be practicing with Zoom for any brain injury survivors. If there's anyone who needs more support practicing with Zoom. I know it's taken me quite a while. Please don't be embarrassed about it. It's new technology for all of us. We're in this together, right? So, and I learn something new all the time. Well, I know I've gone a little bit over time. Thank you so much again for coming out this morning. Carrie?
Yeah, I just want to say thank you to both you and to Kristen. Kristen started right before COVID, and if you've attended anything virtually, it's because Kristen has made it work, both on behind the scenes and even well before the event actually gets rolling. So I want to say a round of applause to Kristen. She works 7 days a week. We've got to get her off on a vacation here, but she's really made our virtual education possible. So thank you to Kristen.
Thank you,
Thanks, Carrie.
Definitely.
All right. Be safe and be well. We hope to see you again. If you are with a provider, remember everything that Dr. O'Connor has kind of introduced you to today. We have supports. We have someone who will, Janice from our staff, who will go out and talk to you specifically about that HELP screening. You are not alone. If you just had an Oprah aha moment, we're here to walk you through it as you think about how it fits for your facility and the people that you serve. So thank you so much for all you do, and be safe and be well.